Let's talk about this topic, the oversimplification of diameters when managing aortic disease. You know me, my name is Arturo Evangelista. I think this is a crucial subject because it suggests that aortic diseases solely revolves around aortic diameters and how to manage them. And many times, the indication for surgery or even the diagnosis itself is based on them. And perhaps we need to nuance certain aspects that this specific parameter entails. The significance of aortic diameters has been thoroughly proven, since we are well aware from seminal studies that really, when the aorta has more dilation, we see the increase of the risk of dissection or rupture. In this well-known study, we observed that as we increase the diameter starting from 3.5, which is considered a strictly normal aorta, strictly normal up to nearly 60 millimeters, the annual risk of rupture, dissection, or death rises significantly. Notice that starting from 59, it increases a lot. So of course at 55 it has classically been considered the cutoff point to indicate surgical treatment in patients. I will cover 7 important points in aorta diameters. Firstly, that up until now we relied on prior classic studies because we need to study the long-term evolution of patients and their risk of complications. We find that the studies were not done in the same way that we are now measuring the aorta diameters. Therefore, we infer things that are sometimes not true. Perhaps it is true that there was a tendency to measure in the axial plane, and this means that the diameters were slightly overestimated. Thus, when we state a diameter of, for example, 55, if measured correctly, it could be under 52. So then, the indications are based on a potential overestimation of the diameters, and we should perhaps lower the cutoff slightly because classically you know that the cuts were quite axial. But on the other hand, with multimodality, we have found a great advantage and a great disadvantage. The major drawback is that measurements are not standardized, and there are different measurement methods, like from cusp to commissure, from mid-cusp to mid-cusp, and the maximum diameter between the cusps, wherever it may be. This, the maximum diameter between cusps, not necessarily mid-cusp to mid-cusp, is the measurement that enables us to determine the maximum diameter for clinical use. Although it may seem that this is very subjective and the variability is worse, it has been shown that the variability is similar to mid-cusp to mid-cusp. And in mid-cusp, there are cases where, if the aorta is asymmetric at the root, it is better measured from wherever to wherever, but from cusp to cusp. Evidently in telediastole and where the aortic wall is not clearly visualized, from inner to inner, from internal diameter to internal diameter. And in multimodality, we apply the same thing. That is, we apply the measurement by leading to leading edge in red, with transthoracic echocardiography, but measuring internal diameter to internal diameter, both in CT and MRI, at the maximum intercusp points, all taken during telediastole. Therefore, once we establish a universally accepted measurement method, we can likely begin discussing something more accurate, because the measurement variabilities are so significant enough to say a diameter indicates some clinical decision. Well, it depends on how you measured it. Now, I think worldwide we agree that we are going to use this way of measuring. The other thing is that even if we use the same methodology, there are still significant limitations in the accuracy of the measurements, which may impact significantly in clinical practice. We think we are really using a ruler, and this is more like a tape measure with the errors it can have. Observe the significant variability present between the measurements obtained by echo and CT scans. We can see variabilities that are very significant, which are usually greater than 2 millimeters, as can be seen here. In addition, we see that with a substantial variability range of 4.5 down to 4.3 in terms of variation. 31% of patients are actually outside the acceptable clinical parameters. Therefore, we cannot assume that a 42 measured by echo corresponds to a 42 measured by CT or MRI, because each technique has its variability. A 2 millimeter variability is the standard. A variability over 4 millimeters should make us suspect either a bad diameter measurement or a real size change. It is absolutely important, but 2 millimeters is standard. Measurements under 2 millimeters, perhaps in the future, once we integrate other parameters like segmentation and automatic border determination by different imaging techniques, this will normalize. But today we are here, so let's not make mistakes, remembering there is significant variability in aorta measurements. And furthermore, even with the superior technique, which is CT due to its best spatial resolution. Notice also that when we do the intra and inter-observer variability study, there is a difference that exceeds 1 millimeter. It is more than 1 millimeter, and the inter-observer is 2 millimeter. This means that even using the best technique, following the identical procedure, methodology, and equipment, but with different observers, we can also find a variability of 2 millimeters in most cases, and this is part of the measurement changes in the best method. So keep this aspect in mind, because in the end, what you will have to do is observe and remeasure when there are differences in the in situ techniques, and you will have to somehow also see if there is a real aorta enlargement, and it is not a measurement error that usually is present when it can exceed 2 millimeters. We always have to think that there is an error in the measurement. Above all this, the guidelines make it more complicated for us. And notice that in recent European guidelines, we have a scaling of management and surgery indications, depending on changes that can be between 45 and 49, between 50 and 52, between 53 and 54, or more than 55. That is to say, we mentioned a moment ago that there is a significant measurement variability that can be 2 millimeters, and we are indicating surgery for changes that are sometimes less than 1 millimeter, depending on what we decide and what we see. Of course, this is a paradox that must be taken into account. Sometimes the guidelines yield results as if they were obtained in series of 300 or 400 patients, and we are managing only one patient, and the errors in 300 patients are compensated, but none in a single patient. Therefore, it is important to consider these aspects, these changes that we can see, as I told you before, between 50 and 52. Furthermore, the phenotype afterwards, whether it is a root phenotype or an ascending high phenotype, the resulting values then depend on aorta dilation location, root or ascending high, and will imply class 1 or class 2A surgical indication. If it is a tricuspid or bicuspid aortic valve, that is, the diameters, the location of the dilation, and the valve type can lead to significant alterations, but perhaps where it dilates is easier to find out, the valve type as well. But the diameters may be the aspect where the most errors are made, and it is important that we are sure of what we are going to measure and observe in the evolution of the patient. The third point, well, is this one I commented on a bit, where this scaling of surgery indications based on diameters comes from. Well, the Yale group, led by Eleftheriades, demonstrated in a study published in the European Heart Journal, was that somehow the diameters were increasing significantly starting from measurements that were 50 millimeters. So, well, 50 to 52 millimeters, it seems that it is already a time to indicate surgery. Thus, the threshold has been lowered from the classic 50 millimeters down to 52 millimeters, based on this Yale study. However, this study also has its limitations in some imaging methods. For example, that the measurements are taken in the coronal plane. When we are saying that we have to measure in the transverse plane with double obliquity, this study takes the measurement in the coronal plane, which consequently introduces uncertainty about whether the measurement is equivalent enough to justify lowering the diameter from 55 to 52, because this is the projection the study uses. And really, although it is an extensive series of patients, well, not all the tags seem to be synchronized with the electrocardiogram, which is another limitation the study might have. The study already mentioned coronal diameter. Some groups say they don't see clearly why we should change the threshold. So this is a significant question about which I will offer my personal opinion at the conclusion of my presentation. It is clear that there might not be absolute evidence. There are other studies that actually find that starting from a diameter of 55 is where it spikes. But the variations between 50 and 55 are not absolutely significant. And therefore, for example, this study concludes that they believe a diameter of 55 is the most appropriate when surgery is required for patients without genetic conditions, and evidently non-syndromic patients, those outside genetic pathology. So there are groups that concur that around the same time frames, extensive groups that do not agree with lowering the DINTEL and say that 55 is sufficiently safe. Other studies concur and state that patients between 50 and 55 face a surgery risk of 1.9%, which is the risk that surgery can present globally, but they have a dissection risk of 1.5. That is, that perhaps between 50 and 55, the surgery itself may be more risky than the risk of dissection at 5 years of follow-up, as can be seen here. So they also say, well, depending on the patient, we might be harming them more than benefiting them because the surgery has a slightly higher risk than the natural evolution. But well, there are other studies that have validated this point and do show that in the aortic root, 50 millimeters is where the risk of complication spikes, and in the ascending aorta at 52.5 and 53, if you want to say so, meaning that it appears the root carries a higher risk of complications than the tubular aorta. And these risks in these series indicate 55 for the root, and starting from 52 to 53 for the tubular section. We are in a phase where I think that the numbers, depending on the series, depending on the pathology that has been included, the patient's profile, produce certain results or produce different results. It's obvious that in genetic pathology, we must be more aggressive because the risk of rupture, dissection, mortality is much higher, and these cutoff points are well established, leaving us with no doubt in series where they change. We can see that in Marfan pathology, the cutoff point is 50 millimeters, and we have in the pathology of TGF-beta, Loeys, Dietz it is 45. When Marfan has a high risk of complications due to family history, dilation, etc. Instead of 50, they operate at 45, and Loeys Dietz usually go from 45 to 40. When there are specific detectable risk factors, a desire for pregnancy, or certain characteristics that classify the patient as higher risk. But if there are no risks, 50 for Marfan is accepted. For Loeys Dietz, 45 is accepted. With risk, strong family history, some mutation type, 5 millimeters less, Marfan 45, Loeys Dietz 40, in some type of TGF-beta involvement, but that does not affect receptor 1 or 2, then TGF-beta 3, for example, like Marfan, at 50 millimeters of diameter. These data aren't questioned. They seem adequate and prudent. Sometimes a patient causes aortic events, and they dissected before these diameters, but that's the exception. The main rule is that this works well. Another question, the sixth point I wanted to bring up is, well, are we going to continue with the diameter in absolute value, or are we going to index the patient's diameters by height, or the diameters by the surface area, body? It is obvious that to define if a patient has Marfan, we use the Z-score, which is 2 standard deviations, but incorporating age, sex, patient's weight and height. And then we can say if the aorta is dilated or not, because notice that depending on whether it's a man or a woman, here we would have a normal value, and here we would have a value indicating dilation. That is to say, it is important to note these differences when saying whether it is dilated or not. but we do not have a z-score to define surgery. So you ask, why calculate the z-score, F a dilated aorta, A if I don't know the z-score predictor value that indicates surgery? Because there are no historical studies reporting these results for surgical indication. Therefore, the problem is this, that we lack history. Perhaps in the future we will have data with z-score. At this moment, what we have data on is indexing the diameter by body surface area or by height. We could state that, as we can observe here in this extensive series from Yale, well, for more than 30 millimeters by body surface area, we already increased the risk, and it is a value to consider for indicating surgery. And I prefer indexing by height because it doesn't account for the patient's overweight or obese status, and so on. And a cutoff point of 32 millimeters of diameter divided by height greater than or equal to 32. We see it's an interesting cutoff point for increased risk. Therefore, I'm not saying you must indicate surgery at 32, but I think it's important to consider this value, and that in the absolute value you have to compare it with the indexing of the diameter by height. And if when you're already at 32, you should probably think that whatever diameter it has, you should indicate surgery, because therefore, a woman of 1.60 meters, the cutoff indexed point of 32 may work much better for her than simply waiting for a diameter of 52 to be reached. It is important to take this value into account, in my opinion. The other last point is annual growth. It is one of the indications for surgery as well. It is the annual aortic growth. Annual aortic growth in the American guidelines and in the European guidelines, but especially in the American ones, it seems they suggest that, well, the aorta grows a lot, that it grows by 2.6 millimeters per year. This does not appear in the randomized studies we have conducted to evaluate drugs like ARBs or beta blockers or similar in Marfan patients. 0.7 millimeters per year appears, but not 2.6. These are classic values that have been carried over, but the aorta dilates less. The same as in bicuspid, for which the bicuspid grows a maximum of 0.5 and sometimes does not exceed 0.3, depending also a little on the dilation. The more dilated, the more it tends to dilate, but these diameters are clearly lower than the guidelines. So this is important information to consider. Also remember that outside of genetics and bicuspid, growth is even smaller, varying up to 0.1 millimeters per year, meaning that perhaps the repetitive monitoring of patients under specific circumstances. If we do not have a large diameter exceeding 47 or 48 millimeters, it is likely excessive in a non-genetic bicuspid context. We should follow up every 2 or 3 years because the changes are very slight. And remember that when guidelines suggest surgery with an enlargement of 5 millimeters per year, I personally haven't found 5 millimeters per year dilations, nor in the European guidelines 3 millimeters per year. It is exceptional to vintages significant changes. When we observe these changes, which can occur but are rare, we should first confirm that we are not making a measurement error and that we are not carrying over errors either by echo or in multimodality. Confirm the growth because the aorta does grow, but exceptionally it grows 1 millimeter per year. It grows much less. In most cases, perhaps the genetic ones, it might grow 0.7 per year. And you can see a whole series of cases. I have marked the Yale group again here, which is the one where the aorta grows more per year. But in the majority of cases, the aorta growth is relatively low. Notice where we are. This is 1 millimeter. Here we have the centimeter per year. We can see that the mean growth is 0.5 centimeters per year. 5 millimeters per year can be reached here when a series of patients were measured classically. But otherwise, growth rate in more modern series is lower. So that we should not be considering this because there are many measurement errors. Both in this study where they grow 0.2 millimeters per year, and in our study on bicuspid where it has grown, measured adequately by CT, it has grown 0.23 millimeters per year. They are an alarm signal. That is, watch out. Perhaps the classic measurements that weren't synchronized with the electrocardiogram, where the right cuts weren't made, resulted in much larger dilations. There is greater dilation in the descending aorta per year, but not so much in the ascending aorta. So refine, and really when different numbers come out, check that the measurements are done correctly, and we aren't truly facing a measurement error before indicating surgery. Finally, other causes besides the aortic diameter must be considered. As I mentioned, the patient's height is an important variable to factor in. Especially women sometimes have surgery late because they do not exceed 1.70 meters or 1.65 meters. In reality, this is a dilation that is less focused on men, whereas women are perhaps less represented in aneurysm studies, and sometimes they operate late. We must consider it. The annual aorta growth rate I mentioned, the patient's age, blood pressure control, and other variables I will discuss, such as the length of the ascending aorta. Well, all these aspects must be taken into consideration whether they are genetically affected or not, because they are extremely important. All this is beyond the diameter and must influence the decision. The length of the aorta. I have already mentioned that recent studies suggest that from the aortic root, from the annulus, to the exit of the supraaortic trunk, really an extension greater than 11 millimeters in the middle part of the ascending aorta is another risk factor to indicate surgery separate from the diameter. If so, it's another interesting value, not just the diameter. In other words, I tip the scales because I actually have a value exceeding 11 millimeters in the distance in the length of the ascending aorta. But to conclude, what I want to tell you is that first, we must reflect on the circumstances and the patient. It is essential to remember that we have derived results from hundreds, sometimes thousands, of patients. And it is a patient that we have in front of us from a whole large series of patients that have been studied, and sometimes with different measurements. And it is very different what benefit we will bring to a young patient of this age, also whether they are sedentary, or like to do sports or physical activity, or a young woman who wishes to become pregnant, and the associated risk, than a patient who is already 80 years old, and that probably with the same diameter, the approach should be different. And this is frequently overlooked. We only take into account the aorta and its diameters, and we do not take into account that the patient is the one who should have surgery, right? In a very near future, because it is right here, we are going to improve all these doubts and these shadows that we see in the aortic diameters, because segmentation will be possible using deep learning, allowing us to know the exact measurement we are assessing in each imaging technique. The image quality will improve even more, and the automation of measurements will generate fewer objective operator changes in the way of measuring. This will greatly assist us both in decision-making and in being certain about which value predicts complications. But also, genetic information improves continuously, and probably, apart from mutations and genetic diseases, we will reach a point where we will genetically have the detection of predisposing factors for dilation. It is not the same for a patient with a specific profile, even a non-genetic one, such as arterial hypertension or other conditions, than another patient who has the same risk factor. But who obtains the best example? Not all systemic arterial hypertension causes ventricular hypertrophy. In some patients causes more atrial or ascending aorta dilation. The same will happen here. Thus, besides genetic aortic diseases, I believe we will soon encounter fundamental information, our genetic predisposition for viewing aortic dilation. And finally, biomechanics studies that are actually underway and that will help us to see what tissue and what biomechanical response the aorta has. All this besides the diameter. In the last slide, I would say that it is fundamental to take into consideration not only the diameters that the guidelines are telling us, which are 50 to 52, 53 to 54, or 55, but somehow think about which patient carries these diameters, that these 3 patients are different, the benefits we will provide them, their preferences, and the lifestyle and quality of life they desire. And on the other hand, also consider, which is very important, their comorbidities, because comorbidity for a surgery that is preventive to avoid a problem is not an aortic stenosis that we know there is no escape, but rather we are trying to prevent an issue. It is a prophylactic surgery, so comorbidities must be assessed very carefully, and ultimately, for surgeons to know their results and what surgical technique the patient can be offered. Will it be a supracoronary conduit, a valve replacement, or a David procedure? We must incorporate all of this. In summary, let's not focus only on the diameters. We try, obviously, to optimize their measurements, but let's look closely at the evolution, at the risk factors, at comorbidities, hypertension or cholesterol, and above all, let's look at the patient. We do not operate on aortas. We operate on patients. And this is the final message of my presentation.